It's a cardiologist at Vithas, Nisa, Aljarafe Hospital in Spain to deliver his talk entitled COVID-19 in Spain and its cardiovascular aftermath.
Thank you.
Thank you again, Dr. Joseph.
Thank you. Thank you.
Hello. Can you hear me?
Yes. Yes. Thank you.
Okay. It is an honor for me to present at this meeting the cardiological situation in Spain with the COVID-19 pandemic. I want to thank the organizing committee for its invitation. Okay. Excuse me. I have problem with the presentation. Okay. Yeah.
But can you share your screen?
Oh, I'm sorry, but
Yeah, it's good.
excuse me. Okay. Well, how
Screen,
it began?
Doctor? Can you shift to the full screen?
Excuse me?
Can you shift to the full screen presentation?
Oh, I don't know. Wait a minute.
Fine.
I'm sorry. Okay. How did it begin? The first information received by the World Health Organization office in China on a series of 27 cases of pneumonia of unknown etiology took place on December the 31st, 2019, with the virus in question being identified as the cause on January the 7th. The first case registered in Spain took place in a tourist on December 31, 2019 on the Canary island of La Gomera. The first, in Spain, the urgent public health measures were established due to the escalation of infection. For example, on March 12th, in line with the recommendation of the European Center for Disease Prevention and Control, social distancing measures were extended to the entire country. Which is the clinical spectrum of the COVID-19 infection? The COVID-19 infection can cause pneumonia, acute respiratory distress, and eventually death in many patients. The symptoms are several. The more frequent are fever or recent story of fever. Varies the incidence rates, 47%, 9%, and 19%. Dry or productive cough, dyspnea, asthenia, sore throat, headache, myalgia, chills, other minor manifestation, nausea or vomiting, diarrhea, or nasal or conjunctival congestion. The clinical spectrum in the heart can represent with the symptoms related to the heart failure or acute myocardial damage, even in those absence of fever and respiratory symptoms. The high incidence of cardiovascular symptoms due to acute myocardial cell damage may probably be related to the systemic inflammatory response, the effect of AC2 dysregulation and lung dysfunction and hypoxia itself. This global pandemic could also have collateral detrimental effects on the prognosis of several diseases, such as stroke, STEMI, pulmonary thromboembolism, and other time-dependent disease. Very interesting is the presence of the cardiogenic shock. We have different cardiovascular presentation with high mortality, and the possible pathogenesis may be myocardial inflammation underlying the acute myocarditis, and the SARS-CoV-2 particle have recently been demonstrated in the myocardium of this patient. The stress cardiomyopathy in COVID-19 may be triggered by the catecholamine discharge secondary to hypoxemia or sepsis, by myocardial injury related to the systemic inflammatory process, by direct myocardial infection with a virus, or by a mixture of factors. Also, the pulmonary thromboembolism is common in the percoagulability state provoked by COVID-19 and can lead to cardiogenic shock with high mortality. It's very interesting, the presentation of the ST segment elevation in times of COVID-19. Back to the last century, a call for attention. In our country, the COVID-19 pandemic can adversely affect systemic care and its outcomes. Currently, a delay has been observed in all components of systemic care that may further affect its associated complication and prognosis. On the other hand, the emergency system is markedly overloaded, leading to a delay in both the diagnosis and treatment of STEMI patients. Which are the molecular diagnostic tests to reduce the myocardial damage and cardiotoxicity? The determination of the genetic variants of AC2 in the population could identify which group has least risks of infection with this virus. The variants SLCO1B1 and BDKRB24 associated with patients with toxicity from a angiotensin-converting enzyme inhibitor and with symptoms too similar to COVID-19 could also be used to exclude false positives. There is also a high prevalence of microvascular thrombotic events in patients with COVID-19. The high concentration of the D-dimer, a protein degradation product of coagulation, have been shown to be predictors of mortality. About the treatment, the basis is very known. Being insulating the patient, the first step to take. Among supported treatment, proper hydration is usually ensured. Antithermal drugs are administered to treat fever. Antibiotics in the event of suspected secondary bacterial infection. Analgesic to control possible pain, and in several critical cases within dyspnea, hypoxia, or RDS, use of oxygen of mechanical ventilation. With regard to specific treatment, due to the lack of solid evidence at July 2, 2020, the World Health Organization does not recommend the use except in the context of a clinical trial of any of the following: chloroquine and hydroxychloroquine with or without azithromycin, antivirals such as lopinavir, ritonavir, umifenavir, or favipiravir, immunomodulators such as tocilizumab, or interferon beta-1a, or convalescent plasma. Which are the Spanish data. The mortality in Spain, these are the data of the last, from yesterday. Spain, we have confirmed cases, 3,376,548 million, with diseases 76,062.5. The higher proportion of deaths has been among the elderly, more 60 or 70 years. The estimated fatality rate fell to 0.8%, 4.1% among those over 17 years, 0.04% between 15 and 69 years, and minus of 0.003% under 49 years. It's very interesting, this national study of any COVID about the zero prevalence, with sample from more than 61,000 citizens, which concluded that the 5.2% of the Spanish population, almost 2.5 million people, had suffered the virus infection and had antibodies. The methods of this study was a telematic survey of 81 centers involved in STEMI networks in the 17 autonomous communities of Spain. Spain, if you can see in this slide, there are 17 autonomous communities with 50 provinces. We are 47 million people. And information was collected on the diagnostic activity, PCI, structural intervention, and PCI in STEMI on changes in the organization of STEMI network. We have in Spain several STEMI networks, and on the prevalence of COVID-19 among interventional cardiologists. Data was compared for the week of February 24 through March 1, before the outbreak, and for the week of March 16 through March 22 during the outbreak. From the results of this study, the highest prevalence of antibodies in health personnel in 10%, in workers in nursing homes and social health centers, 7.7%, or in people who had lived with a confirmed patient, 31% stand out, or with people with symptoms compatible with disease, 15% variation were also found according to the geographic criteria, from the high prevalence in the province of Soria, 14.4%, to the lowest in Huelva. Huelva is in the southwest of Spain, in Andalusia, very near that where I am living, going through 11.7% in Madrid or 7.3% in Barcelona. Conclusions. An important reduction in activity and interventional cardiology has been observed during the COVID-19 epidemic. Likewise, a great decrease has been detected in the number of patients treated in the STEMI networks, where the risks are increased the morbidity and mortality that this represents. The scientific societies and health authorities have to promote that patients presenting STEMI compatible symptoms proceed with no delay to access the health system to receive reperfusion, treatment, and in appropriate way. Thank you very much for your attention, and this is my city, Cadiz, in the southwest of Spain. Thank you very much for your attention.
Thank you very much, Dr. Chulian, and also